Good evening, everyone. And what I'll try to do is to impress upon that how molecular profiling has had an impact on the outcome of cancer. And I taken prototype as a lung cancer. And as suggested by previous speaker also, that this is one of the cancer where the impact has been good, and people do use it routinely in the clinical practice, in the clinic. So let us see why we talk about a lot for molecular profiling, especially lung cancer. This is the important slide to start with. Not long back, 2002, when I was getting trained, the best of the treatment in the lung cancer used to give the outcome of around 8 months in advanced stage non-small cell lung cancer. And believe me, this was the paper which went to NEJM, which I doubt if we have these kind of curves, paper will go to NEJM in today's time. But this value is important to remember, that is 8 months in advanced stage non-small cell lung cancer. And let us see what has changed subsequently, and that may give a hang of it, how things have changed. Now, coming to molecular profiling, this is one of the initial work, and you will see one of the few names recurrently. That is, one is Dr. Amit Dutt, Dr. Anuradha Chaugale, and with whom we collaborated and worked. And this is one of the students who initially in the lab, in Dr. Dutt's lab, did the initial profiling of EGFR mutation. And this put the number, what is the EGFR mutation rate in our population, that is around 25%. And this is stood correct by and large after many data coming in, that is now dozens of data coming in. And this also helped us developing the test for our poor patient, and because the cost was less. Because we were doing the test, we could do a randomized study comparing tablets versus chemotherapy. We heard that chemotherapy is not the best of the treatment, nor the targeted therapy, because all treatments are tough on patient. But no doubt targeted therapy is relatively easier, and especially this tablet, it is easier on patient. So it was good to compare, is it better than chemotherapy? And yes, it showed that it was better than chemotherapy in controlling the disease. And as far as survival is concerned, the overall survival was around 20 months, similar in both arms, the reason being almost 2/3 patient crossing over. So what we remember, what we started with 8 months, and now what we see, that overall survival, if we have a gene, we have a mutation, and we have a targeted therapy which can be given, then the average survival now the patient can achieve is around 20 months. Now, is the outcome similar to what has been there in the literature? It looks like yes. And what we see, that our data looks similar to what is there in the literature today. Now, subsequently, we also looked for, and again, this was talked by, in the previous speaker, that what is our data for molecular profiling. This is again the work spearheaded by Dr. Amit Dutt, and in a collaboration and with his one of the student who is our colleague now, Dr. Pratik. Apart from the discovery, that was the prime and important interest from their side, and this was a very important interest from my side. Sure, it was interest from Amit Dutt and his group side, but from my side, this interest was huge, that what is our profiling of lung cancer patient as far as the adenocarcinoma is concerned. And what we looked, that yes, the mutations are similar, you have some discovery, some differences, but percentages are different. Yes, and it is obvious here, EGFR mutation rate being higher, KRAS mutation rate being lower than as compared to what we have seen in Caucasian population. And this was the one of the first data to suggest that what is the comprehensive profiling for adenocarcinoma lung cancer. This is another work where in one of the family members, where we had lung cancer, and one could do those comprehensive genomic profiling, and one found that HER2 G660D was there in all the 3 patients where the exome sequencing was done, and it looked like HER2 inhibitors were good, and we could give to 2 patients because one of them, they died before that, and it also worked, suggesting that in many of the situations, a few patients' data can be useful. This was another work again in collaboration with Dr. Dutt, that we had double mutation, and this is infrequent, but it does happen, and it leads to always a query that what happens and how do we treat them. In our population, all of them responded, suggesting that if you have EGFR plus KRAS, treat them with EGFR inhibitor, it is good. Sure, we will have an issue now because now we do have KRAS inhibitor also, and then we will be talking about in future how do we treat alone, sequencing, combining, in these patients. Because we were doing this work, we could also had the EGFR mutation data in squamous cell cancer in lung, and we found that as far as the giving TKI and outcome is concerned, it is good, it is better than chemotherapy. So if you have EGFR mutation in squamous cell cancer, treat with TKI, because that's the most important prognostic factor here. We also analyzed our data for rare mutation, that is uncommon EGFR mutation, and it suggested all of them are not similar. Your overall survival varies from 2 months to 22 months, suggesting that as the time goes by, we will learn those different uncommon mutations and also learn how to treat them differently. Now, idea was that we improved from 8 months to 20 months. Can we make it better? Yes, the world was working on many fronts. One of them was to get better oral tablets, and this was a famous study comparing osimertinib, one of those targeted therapy, to the previous targeted therapy. It did improve survival, and what we can see that survival was better, and we were talking about 2-year survival in the range of around 70%, which we have not heard in the past in lung cancer. We were also trying to develop that can we get some cost-effective treatment, because that tablet is almost 1.8 lakh rupees per month for our patients. So we thought of combining this tablet to chemotherapy, and we did this study. That is 350 odd patients randomized between targeted therapy plus chemotherapy. It looks like that this treatment, which costs around 4,000 to 5,000 rupees per month, improves the disease control and also improves the survival and the control of disease. The proportion of benefit is similar to what we can see in the tablet alone. That is a newer tablet, suggesting that there are ways and means where we can work upon and develop treatment for our patients, which is cost effective and good for our patients. We all started with 8 months median survival, and this is one of those recent data suggesting that we are talking about now 5-year survival in EGFR mutation positive patient of 40% and plus, and with the median survival of around 50 months. Remember again where we started with, that is around 8 months. Now this is not alone data. There are at least now half a dozen data in lung cancer with EGFR mutation, which suggests that now we do talk about the median survival of 50 months odd, and again, as compared to what we have seen in the past, that's a significant improvement. And at this moment, for these patients, you have at least 8 options open, which one can choose from for them. We also worked on liquid biopsy, and because that's a challenge for our patients to have a biopsy in this situation, and suggests that concordance rate is around 80%, suggesting that it can be done. Do we restrict to only one mutation? No, there is a good data for ALK mutation positive patient, and this is our survival data. There is a 5-year survival of 33% and median survival of around 35 months in these patients. Again, remember we started with 8 months. What is the international data? This is the median survival of around 47 months or 41 months, depending upon which arm you're looking for. Sorry, 41 months or 47 months. Again, with the first generation TKI in these patients. Again, why this 41 and 47 months is important? Again, where we started with. And again, we are talking about in the term of 4-year survival or 5-year survival in these patients, which we are not talking about these patients which are advanced non-small cell lung cancer. If we take the newer drugs like alectinib and lorlatinib, what we see that we talk about that 5-year survival of 63-64% in these patients, which is unheard of in the past. Do we have some other mutation? This is a ROS mutation data from our own center, again highlighting that outcome is better if you are able to give treatment to them with TKI as compared to not able to give TKI, and Also international data suggesting we talk in terms of median survival of around 51.4 months and 4-year survival of 41%. Again, remember where we started with, that is the median survival of 8 months. Again, highlighting that yes, it has made a difference. Do we have some good news from immunotherapy? We have seen there is a excellent news in melanoma. People have tried in lung cancer. Many of those trials suggest that it does work. It improves life of the patient as far as the quality and also the quantity. What is the data regarding long-term outcome? And here again showing the data in for the immunotherapy that it works and it adds life to the patient. This also works in patients of locally advanced lung cancer, where what we can see that at around 3 years or 4 years, the improvement in survival is in the range of 10 to 12%. And if we see the advanced disease lung cancer patient, 1 in 3 patients, which used to be 1 in 10 patients or 1 in 20 patients surviving at 5 years, now we do have 1 in 3 patients surviving 5 years if they are first-line patients who are treated with immunotherapy, now which we have not seen in the past. So what we can conclude, there have been significant development in management of lung cancer. Targeted therapy and immunotherapy are significantly improve the outcome. It is important to develop diagnostic tests and treatment protocol at local level that makes treatment accessible to the patient. And that's also for the test I re-emphasize, because that's the mandate for today's discussion. There are many other developments which are not covered in this presentation, and tobacco remains the most important preventable cause for lung cancer death. And these are all the students who works within the Dr. Amit Dutt's lab, our medical oncology molecular lab, the coordinator and the resident, because of which it has been possible. And again, highlighting Amit, which has been constant collaboration apart from my colleague, Dr. Vijay, Dr. Amit, Dr. Vanita, Dr. Anuradha, and Dr. Pratik, I told you, are new faculty, and Dr. Nandini, because of which it has been possible, and our lab, which works too closely, and my mentors. And these are all the collaborators and the family. Thank you so much.